So good morning, everyone. I'm just going to give it a minute or two to let people filter in. So you'll bear with me if I'm a bit looking at my screen a bit. So just to say welcome to everyone to the latest assignment talk. We are joined today by Antonia Bura, if I pronounced that correctly. And Antonia works with the HSE Social Inclusion Office and is particularly focused on the health needs of people experiencing homelessness and sort of providing the research that will ensure that the health needs of people experiencing homelessness are being met. It's particularly critically important, I think, that we maintain those services as the infrastructure that's needed to support people who maybe are in the midst of a crisis out of homelessness. We talk a lot about prevention and move on because they're the two key parts of ensuring that we drive down homelessness and make it more rare. But the health needs of people who are experiencing homelessness is an incredibly important element of making sure we maintain the quality and improve the quality constantly of the services that people need, and I think also will give us an understanding perhaps of how we can improve our prevention services as well. So we're delighted to have Antonia with us. Antonia has previously worked in frontline homeless services as a project worker, and she's currently training for qualification as a Humanistic Integrative Psychotherapist. As I said, her main area of work in the HSE is the improvement of access to mainstream and targeted health services. And Antonia holds a BA and MA in psychology and a diploma in predictive data analytics. So with that, I will add two more things. One is to say Antonia is going to speak for 25 to 30 minutes. And then we'll leave questions, as usual, leave questions to the end. There's a Q&A box and a chat box. If you move your cursor down to the bottom of your screen, you'll see them there. And if you want to put in the questions as we go, as they occur to you, and feel free to put more than 1, 2, 3 questions in, we'll try and get to them all, but we'll get to them once Antonia has finished her presentation. And the final thing is, we do encourage everyone to use, if you're using social media, to do posts, tweet, Facebook, Instagram about the Simon Talks. Please do use the hashtag Simon Talks so we can share your messages. And yeah, with that, I will hand over to Antonia. Thanks, Antonia.
Thanks, Wayne, and thank you to Simon community for inviting me here today. So I'm just going to share my screen now. And I hope you can all see this. So I'm just going to tell you a bit more today about the health needs of Housing First participants that we are learning more about through the implementation of the Housing First health monitoring tool. So just to start, first of all, with the reason why the Housing First is important. So Housing First usually yields higher housing retention rates. Also, it results in lower returns to homelessness, and it significantly reduces the use of crisis services and institutions. But actually, most importantly, what it does, it is housing those who would be the most marginalized among the marginalized ones. So we are talking about individuals with long-term histories of homelessness and complex health needs who maybe have not been engaged with any services for the last 5 or 10 years. So from that perspective, the Housing First program is really an evidence-based intervention that provides a comprehensive and holistic approach to addressing long-term homelessness for people who would be experiencing either mental health, physical health issues, substance misuse, or other social, behavioral, and other challenges. So just when we think about the Housing First in the context of Ireland, any strategic alignment and policy development, we can see that it has been identified as one of the key actions in Housing for All policy. Also, Housing First National Implementation Plan has been published last year, which is really guiding the development of the Housing First program up to 2026. Then as well, it has been identified as one of the key priorities within the document that National Social Inclusion Office is developing, and we hope to publish soon, which is a strategic framework for the health of people experiencing homelessness. And that document is going to inform the work of our office up till 2026. And then as well, it has been identified as an action within the HC National Service Plan for 2023. So now going back to the Housing First Health Monitoring tool. So the general objectives of the tool are really to monitor outcomes related to health, social integration, and quality of life, including as well service utilization and support needs. We also want to better understand the resource requirements as the program develops, and we want to compare the models of healthcare provision across regions, just to inform the program and service development and to see what is working well and what needs further improvements. So the aim of the tool is really to collect good quality data from Housing First participants in order really to understand their experiences and then to use that understanding to improve our services within the program, and then hopefully as well to improve the health outcomes. So in order to do that, we want to find out more about their health and social needs. So we would be collecting the data over the time at 3 points in time. So we're collecting the data at the baseline, which is really when the Housing First client just enters their tenancy, so they're new to the program. Then we collect some amount of data 6 months after, and then again 12 months after that. So when we do that, we're really able, to say that maybe any kind of like differences, any changes that happened in between are really result of the Housing First program. So when I get to the data part, just bear in mind that all of the data I'm going to present to you today are from those who have just entered the Housing First program. They're new to their tenancies, or they've been in it for a maximum of 1 month. So why are we doing what we're doing, and why do we want to know more about the Housing First clients? So as I already mentioned, usually Housing First participants, they might present with higher complexities. For example, mental health issues, physical health issues, substance use, or quite often what we see is really a combination of all three. So really to learn more about their health needs and then to explore how the Housing First program can as well successfully support those needs, we take a person-centered approach. And that really means giving each Housing First client the choice to participate in the Housing First Health Monitoring tool, and then as well empowering them to do so. Because by gaining their insights, so by capturing those experiences and by placing them at the center, Housing First clients actually become involved in co-creating our services. And the reason why and how we want to achieve that is that we hope that the final outcome of all of these data we're collecting is really to have supports in place that are going to be tailored to the needs of the Housing First participants. So the data we collect and the tool we have in place is really providing us with an evidence for needed resources, and then as well to identify further needs for health supports. So that way the Housing First program will provide supports to their clients that are more tailored to their needs. And then as well, again, we hope that those supports are going to support their recovery. We're also able to disaggregate data across the regions and share this data. And that way, the regions can use the data for their strategic planning, or just to improve the services in locality and to identify the need, and then as well to obtain the resources to address those needs. So now I'm just going to go through the data that we collected so far, and just to say that the sample size we have in place is still relatively small. So just bear that in mind, that the results we have, we wouldn't really be able to generalize them to all of the Housing First population. So we still need to continue to kind of build the information we collect to have good findings in place. So far, data have been collected for 80 individuals, of which 20 of them were assessed as having no insight into their behavior due to very complex support needs. So for example, they might have been experiencing psychosis, and because they have been experiencing psychosis, they were just not maybe able to give answers to the questions. So in those instances, case managers went to fill out so-called levels of functioning assessment. in which they are answering the questions based on their direct observations of the client or based on their historical knowledge they would have on the client instead of asking their client questions directly. And we can see that this specific cohort, so when you look at graph 1, we can see that they would have almost quite kind of like, they would require quite high levels of support with almost developing these like really basic living skills. So for example, 50% would need assistance to meet nutritional needs. Then 44% would need assistance to maintain minimally adequate level of personal hygiene. And then highest percentage would need assistance to acquire and maintain a network of family, friends, and peers, so 63% of them. Now, this cohort as well would be characterized by higher percentage of morbidities. So, for example, 47 participants were assessed as having a chronic medical condition, and then 78% were assessed as experiencing some form of mental health difficulties, and for 40% it was reported they were using substances. Now, when we look into the service utilization in the 6 months prior to them entering the Housing First program, we can again see high levels of instability. So you can see that, for example, for 70% stay temporary with friends and family, and then 55% would be sleeping rough. You can see that 65% has been hospitalized as an inpatient for psychiatric needs. And then, for example, 30% would have stayed in prison. So it could be as well that, you know, some of these individuals might be in this kind of like a circuit of homelessness where they have an episode of homelessness and they access emergency homeless emergency accommodation, and then from there they might have gone to prison, and from prison they go back into homelessness, and maybe from homelessness they go into hospital and so on. So those are individuals who would be interacting with the system quite a lot, but they kind of always slip you know, through these like a network of supports until they actually really get to the Housing First program. So it's really going to be great to see what happens with these clients, for example, 12 months after, and if they're still being housed, consider the kind of like a levels of chaos and instability they had prior to entering the tenancies. Now we're getting to the part 1 of the tool, which is really looking into the health service utilization and access to community services. And the data I'm going to present you now are from those who are able to give consent to participate in the data collection. So final sample includes 60 respondents, of which majority are males, and then 36% are females. We can see that 81% would be white Irish and 13% are Irish travelers. And then as well, majority are in long-term unemployment, 39%, and 34% are unable to work due to permanent sickness or disability. So that really kind of serves us as a proxy measure of levels of disability in this population. We also wanted to kind of find a bit more about the service utilization of emergency services. So we would go and ask the client, so in the last 6 months, how many times have you, for example, accessed emergency department? Again, this is 6 months prior to entering the Housing First program. And we can see that in the case of physical health, there is a relatively high service utilization of emergency health services. So for example, 38% clients reported visiting emergency department at least once, 25% use ambulance, 25% has been hospitalized, and we can see as well relatively higher engagement with GP and the nurse. When we look at mental health, we can see that 37% reported being admitted to a psychiatric unit, and then as well, more than 50% are receiving medication to support with their mental health. Now, it's really important to kind of keep an eye on this percentage of those receiving medication for mental health as well, because there is nothing wrong to receive medication for mental health problems, but it's really important to be mindful that people do not end up being overly medicated, which can often happen with vulnerable populations and those experiencing homelessness. So as I said, like as important it is to have an access to medication to support with mental health issues, it's also really important to have access to some other interventions if the person wants to engage with them, such as, for example, maybe talking therapies or any kind of volunteering activities and so on. And we can see as well that in relation to the diagnoses that were given, they reported like leg infection, lung issues, COVID-19, schizoaffective disorder, and so on. Also, when we had like a closer look into the data, what we noticed is that same individuals would kind of be responsible for a higher service utilization. So for example, same person would maybe access emergency department 2 times, and then they would use ambulance 2 or 3 times. And maybe as well, they would stay in the hospital a few times and so on. So that's usually the same pattern that can be identified in a general homeless population as well. So it's almost like you have a small cohort of people with really complex needs who would then be accessing services significant number of times. So it's really then how do we support those clients. Now, when we look into the substance use, we can see that 53%, so majority reported using substances or gambling. And of those who reported using different substances, highest percentage reported using alcohol, followed by cannabis, heroin, and benzodiazepines. Percentage of those who reported using crack cocaine is at 9%. We do know, however, that the crack cocaine is becoming an issue in some of the regions. So I think as we continue to collect more data, we are expecting to see that percentage increasing. And also just to say that the same individual could account for multiple substances. So although one might be using different substances, and for example, heroin, wouldn't really, when working with that client, we wouldn't be telling that person, you know, do not use heroin, it's not healthy for you, they know that. But what we can do is that we can implement harm reduction interventions, for example, which is really about how do we reduce harm caused by drugs. So for that reason, we also wanted to capture a bit more information about the engagement with harm reduction services. And for example, 22% reported receiving opioid agonist treatment, such as methadone, for example. 24% would be receiving prescribed benzodiazepines. And then 20% as well reported being engaged in some form of addiction treatment or addiction support, such as, for example, Narcotics Anonymous. Which is actually quite good percentages, again, considering that they're new to the program. So we're going to be really keen to see how these percentages maybe change over time, and if more people engages with harm reduction services. So now we are getting to the access to community services. I really wanted to find out a bit more about the engagement with different health and social services. And the engagement can range, for example, from I'm currently engaged with a service and I received the treatment, or for example, I have been denied access to, I have been engaged with the service in the past. And we can see that highest number of participants are currently engaged with general medical services, so 60% of them, followed by community mental health services and community addiction services. Small number would be on a waiting list to access services. But when we look, what we were specifically interested in is really the areas highlighted in red, which is really capturing those who said they are not engaged with the service, but they feel like they want to be. So that's really about their choice. What do they want to access? And we can see that the highest need identified is to access dental services for 34% clients, followed by employment and training services where 27% participants said the same. So I guess this is really important to keep in mind, this percentage, especially for employment and training services, because often we can focus on pathology and we can focus like on mental health issues and substance use issues, maybe forgetting about this piece of community integration and how I think we still need to do further work to progress that piece of housing first programs, so how to make clients more integrated into society again. And we can see as well that number of those who needed service but they were denied access was reported only for dental services and for mental health services. I think it was only one client. Now we're getting to the part 2 of the tool, which is really telling us a bit more about the severity of health conditions the clients have, specifically about severity of mental health and substance use issues. But we also wanted to find out about a bit more about the physical health and the quality of life. So when you look into this diagram over here, we can see that the percentage of our housing first sample stating they have no problems across all these different health-related quality of life dimensions is consistently lower as compared to Irish general population. And this difference is actually the biggest for anxiety and depression domain, where 27% of housing first sample reported having no problems, as opposed to 78% of general population. Now, again, our sample we have is still relatively small as compared to the sample of Irish general population. But I think, you know, this is still useful finding that really indicates maybe the level of mental health issues among this cohort. When we look into the severity of addiction, we can see that 34% had a score of 3 or more, which really means that across all these different items here on the right, they have experienced problems in the last month 3 or more times. And that would really indicate high severity of addiction. So 34% could have been classed as having a high severity of addiction. Also, just to say that there is a certain percentage of those who would be in recovery as well. When we look into psychiatric symptoms, so we use Colorado Symptom Index measure for that. So 29 individuals scored 30 or more, which is considered to be a clinical cutoff score, which means again that 47% could be considered to need further psychiatric assessment. So again, if you look at this like graph on the right, so the people like we would really like to see being engaged with the mental health services here in this like red circle. So those would be those 47% who definitely need to be engaged with maybe different types of mental health support, different intensity, but those who would have quite high scores would need maybe psychiatric assessment. And then as well, we have a scale of achieved capabilities that was developed by Dr. Ronnie Greenwood and her colleagues. And it's a really great tool that's measuring how the Housing First program is really supporting participants to become more integrated into their community, to maybe become more politically active, to become more optimistic about their life. So it's really related to this kind of like a growth recovery. And the average score for achieved capabilities was 3.4, meaning that in general, Housing First clients, they do feel supported by the program in achieving their goals and becoming part of the community and feeling optimistic. Now, again, as I said, these are the clients who have just entered the Housing First program. So this number is great considering they're really new to their tenancies. And I think this is only going to increase when we do 12 months follow-up, when people have actually had the opportunity to spend more time in their tenancies and engage with the services and with frontline staff as well. We have as well developed a training to support the tool implementation, and it's available at the hscland.ie. And this is for frontline practitioners that I just have to say really big thank you, because they have been absolute tremendous support in supporting us with the tool implementation. So the training is really to support them as well with the way how they collect the data, because a lot of them wouldn't maybe necessarily have any prior experience in data collection or any research. So this is kind of like a useful resource for them to engage with. Also, just to say as well that the tool itself is really a live document, which means that we're going to change it over time. We want to make it as user-friendly as possible, and then as well through engagement with service providers and by attending community of practice, we have become aware of maybe emerging needs taking place that we haven't been aware before. So we have, based on that, we added the new sections in the tool, which are going to capture a bit more information about the personality disorders, then as well about different types of disability, engagement with health services, and then as well availability of services in the locality, because we did notice that there can be massive differences in the services being available in more rural areas as opposed to urban areas. So these are like some of the issues we need to be as well addressing going forward. So how does really this kind of how does this tool and the health assessment can really help one's organization and then as well healthcare providers? So it's going to provide an evidence that helps to guide decisions about commissioning and providing services. It can also identify needs that need to be met, barriers to care and health improvements. And it also enables service providers to work out which interventions are needed most to support the program development, to plan strategically what services are needed in the future, and also to work out where resources should be focused based on evidence. So for example, if we notice there is a significant number of those who really have issues with basic living skills, that means that priority should be, for example, occupational therapy. Or maybe there's a significant percentage of those who might have substance use and mental health issues, and then the priority should be dual diagnosis, or maybe both, for example. But from that perspective, it can be really useful to kind of plan for the emerging needs or what is needed in the future as well. And just to say, I guess, that the tool itself is not really just about collecting the data, it's also about how can we use it in the case management purposes as well. So usually when you're working with people from vulnerable groups or with people from, at the margins, it's really important to make sure that every contact counts. So when you are doing any kind of a sort of assessment, make sure to do it with respect and empathy, and then also to use it to empower people to maybe open discussion about certain questions and to make them more engaged with services and with the system. So for example, if there is a strong desire to access employment again, so then the tool can be really useful to use that as an opportunity to inform them of their options and offer support, such as, for example, CV writing, or to support them to access certain services and so on. So this is just an example of the gaps in the service delivery we are seeing at the moment, and these are based on the data we are collecting, and then as well on the findings of the National Housing First evaluation, and based on the findings of the action research done by Genial. So the gaps in the provision of wraparound support services, they would vary across regions, but regions predominantly report limitation in access to psychology, psychiatry, dual diagnosis, and then as well occupational therapy and outreach support for mental health services and disability services. And one of the main issues identified both in the action research and National Housing First evaluation is access to community mental health and dual diagnosis services. And it continues to be really important to develop clear governance, including clinical governance structures and protocols. Also on the positive side that we're seeing taking place, so some of the key enablers for delivery of health supports are better service integration that is taking place as a result of the Housing First program. So regardless of the service delivery model, improvements in integration between community supports, tenancy support services, and health supports at the individual practice level have been documented in every region. And then as well, there are some structural changes taking place, again, as a result of the Housing First being implemented, such as the co-location of services and provision of assertive outreach services, which is really having a positive impact on service delivery and participant access to services. And then again, this really like a person-centered aspect of the Housing First program, which is really one of its key pillars, is ensuring buy-in and support at frontline and senior management levels. And that's really important to make sure that the program is actually sustainable over the time. And just like to say as well that I guess, the key to the success of the Housing First program are really collaboration and better integration. So from that perspective, Housing First really serves as an example of integrated strategy, which moves beyond this single model intervention, such as, for example, a clinic that would only provide a certain form of treatment, to really form a network of interlinked support. So we have health, we have housing, and then we have NGOs and community services all coming together to support people with really complex needs. And the result is that individuals who were previously believed to be unable to live independently are actually, with the support and encouragement of the Housing First key partners, they're being housed, or they're successfully maintaining homes of their own, and they're receiving supports for their needs. And I hope that the data I showed you today really illustrates the level of complexities of the people who are entering the Housing First program. And with that as well comes really like a big work to support them, especially from the frontline practitioners. So that's my last slide. I just want to say thank you for joining today. If you do have any questions, please do get engaged. I'll have my email address over here, and then as well links to National Social Inclusion website and Twitter account. There's also a really useful resource called drugs.ie. So if you want to know more about any addiction services, harm reduction, emerging drug trends, feel free to access those resources. And yeah, please do get engaged if you wish to do so. Thank you.
Okay. Thank you, Antonia. That was superb. It was really enlightening. I think it shows, I think, the potential and the impact of Housing First, and also the challenges. I suppose just to say, as I think Anna has put it into the chat box there, but do ask questions in the Q&A as they occur, and I'll put them to Antonia. I suppose to start off, just a technical question about the monitoring tool and your analysis of the data. Are you sort of monitoring on a time basis, i.e. the total population divided by the time they've spent in Housing First, or are you actually tracking individual clients through the system? Obviously, you're not sharing data on individual clients, but as you collate it.
So we would be, I guess, doing the both. So because it's kind of like a longitudinal study, let's say, in itself, so we can look at only those who are new to the Housing First program. So for example, those who have just, so as I said, like 60 of them who have just joined the Housing First tenancy. But then when you do 6 months follow-up and 12 months follow-up, we're following the same individuals, of course, those who have agreed to continue to participate. So we'll be able to kind of give this an overview of the health of people when they just enter the tenancy, and then, do the follow-up. So what happens 6 months and 12 months after for the same client, how their maybe behavior changes, or emergent access to community services, how that changes. Are they engaging with services more? If not, what are the issues? What are the barriers? And what do we need to really support them and to open those pathways into care?
Mm-hmm. I suppose the other aspect, as I mentioned at the start, the other aspect of this is the potential for sort of expanding out beyond Housing First as well. I think there are a couple of very stark statistics in there about people entering homelessness, like very high levels of people who'd shared with family and friends, had a psychiatric episode. And I'm just wondering how maybe into the medium and long term we would look at this data, or maybe engage more with service users and clients to understand their pathway into homelessness, because while there's an awful lot of very good work has been done on families as a more recent phenomena, less work has been done with singles, although I should acknowledge DRHE has been doing some work in this area, some very good work. But I suppose, given that those who are in the Housing First system are generally those who've become most entrenched in homelessness and are perhaps sometimes the hardest to reach, there's probably enormous potential there in understanding the pathways into homelessness of those men and women, and how we might work towards preventative strategies as well.
Yeah, definitely. And I think there is something as well about maybe kind of integrating current data systems that are in place, because it's not that the data is not there, the data is captured. I think there is a massive amount of data. It's just not really integrated well enough, like a PASS system and then the health system and the data system that NGOs have in place. So I think if, it has also been identified as one of the priorities now in our strategic framework, just to make sure that we can bring maybe all those different systems together. And I'm pretty sure that we would be able effectively to identify those who have very complex health needs and maybe catch them earlier, and then see what are the reasons why they enter homelessness and see how do we implement those preventive measures in place. But I think the system is there. It's just really how to bring it kind of together. I think it's this collaboration piece and GDPR that we have to kind of work with. But if we achieve, I think it would be really great. To develop the effective interventions as well on the system level.
Yeah, I think that there's enormous potential in that. I suppose to move to one of the other points you mentioned there, which I thought was really interesting, was that Housing First has made a contribution to greater service integration. And I think we did some research with Joe Finnerty in UCC, looking at the impact of COVID on services and the response to COVID. And one of the things that came out of that as well was, having seen the success, sort of the coordination that happened around COVID, because we had a health kind of emergency, and the impact that had, the positive impact that had on people's experiences of homelessness and supporting people to move on from homelessness. I think there was it gave an impetus and increased collaboration. And I wonder if Housing First is having a similar impact, because we know the positive outcomes, the housing retention rates of people who've come into the Housing First system, who perhaps in the sort of the old thinking would have been thought of those who maybe were hardest to reach and hardest to help, and maybe wouldn't have been thought of as people who could maintain a home. And I'm wondering if the success has contributed to the service integration, because people see the success, so it's building on success, which in turn should see more progress.
Yeah, and I think so, and I hope so. And I think Dr. Linka Hill from Genio, she's action researcher. I think she's going to hope to publish soon the paper on the Housing First. It's actually going to touch more so into those aspects. But I think that's what happened, at least in some of the regions. And really, even, there are new maybe pathways into care, and where it's easier to access health services, not just for the Housing First client, but for the broader homeless population. And that's really the effect we want to see taking place, that those pathways that are created are not maybe just reserved for like one program or one intervention, but it's really possible to expand them to other populations as well. Again, if something becomes accessible to, for example, people experiencing homelessness, that also means that it can go even broader, really. So, it can become easier to access it for ethnic minorities, for travelers, for example, because all of them would really be socially excluded groups, people in addiction, and so on. So I think it really changes the way that people think in all of these kind of like key managerial positions. And as I mentioned, that the fact that Housing First is so person-centered, and I think when they see the dedication that people put into the program, the amount of work they do to really kind of pull that forward and to support the clients, they're ready to buy into that, and I think it really opens like a lot of doors for the system to continue to develop, which is not to say that we don't have much like further work to do. We do, But, you know, even like those small tweaks in practices can really make a big difference for people who are actually accessing the services. For example, having a bit more flexible appointments that, you know, if you don't show up 3 times, you lose the appointment, which we all know it's a bit ridiculous, but, you know, small tweaks like that can really make a difference for somebody's care and the treatment as well.
Okay, so just to, I suppose, to keep up on that, is there anything in the data that would point to that differentiation? I know you, because you talked about kind of different, without naming and shaming or anything like it, but the different regions, is there where there's better coordination, or maybe not coordination actually, but more services more readily available? Is that, does that appear, the impact of that appear in the data? I know it's early in the research as well, but is that appearing at all in the data?
Yes, I think we would have to continue to collect more so data to really to give answer to those questions, and then segregate the data across the regions, which we still didn't do, but we hope to start doing that like in the next 2 months. But I know from the monitoring meetings they would have with different regions and service providers being present there, I think, you know, maybe like regions like Dublin or Limerick or Cork would have more services available in the context of health services because they have been there historically. And then when we look into more like rural areas, we can see the lack of those services where, you know, clients have to maybe travel a longer distance to access the services. So that's something we really need to be mindful of. And, you know, if there's a lack of services, can we maybe implement outreach into tenancies then to compensate for that lack of services? But it's definitely, I think, something we'll be able to look more so into future when we have a bit bigger numbers across the region. I think definitely it's going to tell us more.
And another aspect that you picked up was on the tool developed by Ronnie Greenwood. You're talking about sort of almost, would you describe it almost as the way I suppose the way I took it in, it just on that slide, was that there was almost an optimism at the start for people where they really felt, you know, securing their home has opened up, you know, all this potential for them, and they're in a sort of, you know, it's all relative, but in a good space at the start. And would you anticipate that that can be maintained and built upon, or is it something that, you know, people, there's the initial adrenaline rush of getting your own place, then there's a settling in period, and then we lift again? Or is there any kind of is there any interesting trajectories in that happening?
I think it's going to increase over the time, you know, and I think often what happens to people is that they have been surviving for so long, and then when they enter their tenancies, it's like maybe they just need some time to breathe, you know. Yeah. And it's like you have to learn all these skills from the scratch, like maybe how to be mindful of your electricity, how do you maybe cook something, you know. So it's really like building the recovery step by step. And achieve capabilities, it's really about the recovery, growth-related recovery. So it's about having some meaning in your life, about achieving some goals and feeling like you are welcome to your neighborhood, which is not really just about our housing first clients, how they feel. It's also about the community itself. And I think community sometimes has to work. How welcoming are they to the people in their areas? You know, I think it's something that's going to increase over time. But just to say as well that recovery itself, it's not a linear process. So sometimes you can go 1 step forward and 2 steps back, and then 1 step forward. You know, it's like I see it like wave rather than something like linear progression. But I do think it's going to increase over time. And just recently, we actually had some conversations with our Canadian partners in Canada, who have long experience of housing first program, and they were saying that I think on the whole, like in Europe and in the Canada, wherever the housing first program is being implemented, we all need to continue to progress the work of how do we actually support clients to become more so community integrated. So that's almost like a piece that's, you know, that's not as strong anywhere at the moment in like different housing first types in Europe and in Canada. So I think that's like a lesson for us as well. And that's what we can see from the data, in relation to accessing employment and training and volunteering. So that actually really maps back into achieved capabilities. You know, it's how optimistic do I feel about my life? Do I read the newspapers? Am I interested in politics? Am I interested in my environment? So I think that's the piece we really want to continue to progress going forward. And we do have one of the posts that we hope to implement this year, which is called Social Prescriber. And it's really about linking individual into those like community networks and different activities, whatever they're interested in, because at the end, all of it goes back to choice as well. And if that proves to be working well, I think it's something we can really look at and see how do we maybe implement those posts more nationally as well, and see, you know, what we need to improve, what's working well, which services are accessible, which are not. But yeah, definitely really important aspect of recovery.
Yeah, and I think it goes to reinforce, I think I'm conscious of the audience of these talks, and most people will know what I'm about to say, but I think it really reinforces that housing first is just that, it's housing first, and then it's the wraparound supports that really help people to maintain and build their support structure around themselves that allow them to maintain that home and then, you know, progress from there. It's not they sometimes in the rhetoric around housing, it's just about providing people with the home, which is obviously the critical part and why it's housing first, but it is that the wraparound supports that are so critical to the success.
Yeah, absolutely.
And I know you and I had a conversation previously with a colleague in the US who's done some work on the health outcomes of people experiencing people in housing first. And I think what it really does reinforce as well, sort of to run that out, is back to that opening comment about prevention, is that the housing first really is a response to those who've had that experience of becoming entrenched in homelessness, and for whatever multiple factors have contributed to that. But it's also when you look at the health impact of homelessness, of people entering housing first, I suppose what the crisis of having that long-term experience of homelessness has done to them physically and mentally, it does reinforce that idea that homelessness is something that we need to end before we need housing first, which I think is a really critical part of understanding the importance of housing first and how it absolutely is the way forward, but it needs to be part of a broader strategy.
Yeah, absolutely. And I think, you know, it's important to note as well that still majority of people do enter homelessness due to systemic reasons, you know, and it's poverty, which is really number one. But homelessness is always an unhealthy state. So you can spend in homelessness 6 months or 12 months. Like, nobody should spend any time in homelessness, but it always it can impact your health in some way, either like it's physical health, substance use, or mental health issues. I do think like it's always unhealthy state to be in. So yeah, I think prevention is the key.
Okay, we're now almost at 10 to 11. So if anybody wants to pop a question into the Q&A or chat, do. But if not, we might finish up a little bit early. Just to say thank you to Antonia, because that's been really enlightening and a really nice discussion as well. So thank you very much for your time and for sharing your expertise and your research. We are going to, I think with your permission, if anybody who would like the slides, we're going to, I think we circulate them anyway, along with a recording of the talk itself. I think the data is incredibly rich, and it's only going to get richer with time. So I think it's really great to have had the opportunity to get this early view of the amazing work that you and your team and your colleagues are doing there. Okay, so again, with our thanks, and thanks to everybody for attending, we'll finish up there.
Thank you.
Thank you so much, Antonia.
Thank you.